Good day, everybody, and welcome to Gynecological Pathology Community of Interest meeting. Today, the session will be moderated by myself, Anna Plotkin, Director of Continuous Professional Development at the University of Toronto, and Dr. Anjelica Hodgson, GYN Pathologist at the University Health Network. We'll have a 2-hour session that will be focused on new developments in cervical pathology, a talk by Dr. Simona Stolnicu, our guest speaker. Then we will have case presentation alternating between Dr. Simona Stolnicu and our gynecological pathologists from the community. We'll get as many cases as possible. And I really want to thank everybody who volunteered to present cases today. Remember to put your questions and discussion items in the chat, and the chat will be monitored by both of us. Don't forget to fill out evaluation, and especially if you can give us your opinion about the session and suggestions for the next sessions, that would be very good. And the recording of the sessions will be available on the University of Toronto Continuous Professional Development website almost immediately after the session. And with that, I would like to ask Anjelica to introduce our guest speaker.
Yeah, thanks, Anna, and thanks everyone for joining in today from wherever you are. It's my pleasure to introduce our guest, Dr. Simona Stolnicu. She is a Romanian professor of pathology with special interest in gynecologic pathology and specifically cervical pathology, and also breast pathology and cytology. She did her training in Romania, followed by extensive subspecialty training at different institutions in the US and other countries in Europe. She has an impressive academic record, and she has authored over 160 peer-reviewed scientific publications and 30 medical books as editor or main author, including, importantly, the latest WHO 2020 Blue Book on tumors of the female genital tract, and also the International Collaborative on Cancer Reporting of Carcinoma of the Cervix dataset. She is a board of directors member and global advisory network member for the International Society of Gynecological Pathologists. And she has extensive experience as an educator and organizer for numerous continuing medical education initiatives, as you can see, for a number of different societies and such. And it's our absolute pleasure to welcome her today. And I will hand it over to Dr. Stolnicu.
Thank you very much, Anjelica and Anna, and really happy to be present tonight. It's in Romania, it's evening now, and for you it's daytime, and to give you an update on squamous cell carcinoma of the cervix and the precursor lesions. So as you know, cervical cancer is the fourth most common malignancy to affect women worldwide. And despite the really enormous effort that has been put in some countries to decrease the incidence and the mortality associated with this tumor, we still have countries that are facing an continuous increased incidence and associated mortality. And these countries are in Africa, Asia, South America, and East Europe, with Romania, my country, having the highest incidence and mortality associated with cervical cancer. As you know, most of the cases are represented by squamous cell carcinomas. So we're talking tonight about the most frequent tumor, malignant tumor of the cervix. And in contrast, this is interesting, in contrast to so many advances and interest that has been paid to endocervical adenocarcinomas, there is less information on squamous cell carcinoma that has been published in the last decade. And this is also because traditionally all these tumors were thought to be linked to the HPV infection, and negative HPV negative cases were attributed to low sensitivity techniques. This is the WHO 2014 classification, so the previous classification, which was a morphology-based classification, including usual non-keratinizing and keratinizing type, as well as basaloid, lymphoepithelioma-like, papillary, and warty types. And there were some problems with this classification. One of the problem was that the usual type was divided into keratinizing and non-keratinizing type based on the presence of keratin pearls, but really how many pearls to differentiate between the two types was not provided by that particular classification. And usual type as well as other histologic types were all thought to be HPV driven. The prognosis was debatable and the reproducibility among tumor types was low. And this is something that we have demonstrated recently in a paper in which we have managed to collect over 600 cases of squamous cell carcinomas from 10 international centers. And we have compared the original tumor type versus the consensus tumor type based on this WHO 2014 classification. And we have demonstrated that the kappa agreement between original and consensus tumor type was low, and so was the predictive value for original and consensus tumor types regarding overall survival and progression-free survival. And this is mainly because that classification 2014 did not provide sufficient data to enable reproducibility among tumor types. However, more recently, some studies did demonstrate that some of these tumors are not HPV driven. There were not many cases, like 3 cases in a Swedish cohort, 6 cases in an Austrian cohort, 12 cases in a Spanish cohort, but altogether, apparently, 5 to 10% of squamous cell carcinomas are HPV independent. And based on this, and to be in line with the WHO classification for endocervical adenocarcinomas and for vulval carcinomas, WHO 2020, the latest classification that we're using currently, divides squamous cell carcinomas into HPV-associated and HPV-independent. Histologic types have become histologic growth patterns with no prognostic significance. HPV status is considered a prognostic and a predictive factor, but we don't have too many data to prove this, only a couple of studies. And we are still having questions unanswered regarding what's the morphology of the HPV-independent squamous cell carcinomas and how can we diagnose these tumors? Do we need ancillary tests to diagnose these tumors or not? And WHO 2020 classification did not include an HPV-independent squamous precursor lesion simply because at that time it was not described yet. So to answer to some of these questions, we have collected about 400 cases of squamous cell carcinomas that we have tested for P16, low risk and high risk HPV by each. And out of those cases, 10 were negative for all these markers. So 10 cases were HPV independent. And interestingly, these cases occurred in older patients. Mean age was 72, comparing to 50 years in HPV-associated tumors. They were diagnosed at the FIGO higher stage. Most of the cases were in stage 3 and 4. They were both keratinizing and non-keratinizing morphology. 2 out of 10 cases were P53 aberrant. 1 of the 10 cases had metastasis in pelvic organs. 2 out of 10 presented with distant metastasis, and 3 out of 10 died of disease. But we were not very happy with these 10 cases, so we managed to collect 49 cases that we have compared to 363 cases of HPV-associated squamous cell carcinomas. And we found similar results. Most of the patients that had HPV-independent tumors were older with larger tumors in a higher stage. 7 were associated with uterine prolapse. HPV-independent tumors were more frequently of keratinizing histology, and P53 was more frequently abnormal. And overall, HPV-independent tumors had a worse survival comparing to HPV-associated tumor, but the worst of all was HPV P53 abnormal category. So this is an example of HPV-associated squamous cell carcinoma that you can see is P16, block type positive, and P53 is wild type. And then we have two cases of HPV-independent squamous cell carcinomas. One is keratinizing and one is non-keratinizing. Both are P16 negative. One is P53 wild type and one is P53 aberrant. So there is a significant overlap between HPV-associated and HPV-independent tumors. And based on morphology only, we cannot really differentiate between these two categories. So the role of the immunohistochemistry and the HPV test is crucial in these cases. And P16 is a very good marker for the presence of high-risk HPV infection. And in HPV-associated cases, like in this picture here, it is block type positive. But sometimes, even in HPV-associated tumors, P16 can be negative due to various technical problems. And even the HPV by ISH can be negative in HPV-associated tumor, for example, in cases that are associated with HPV subtypes that are not captured in that particular test. So true HPV-independent tumors should be both P16 and HPV by ISH negative. And then P53, which is an accepted marker for the P53 mutation, would probably further classify these tumors into P53 aberrant and P53 wild type. And because we don't have criteria to diagnose these tumors in cervical pathology, we have to rely on criteria from the vulvar pathology, the ones that Dr. Tessier-Cloutier and co-authors have proposed in this paper, in which P53 abnormal is continuous strong nuclear expression at the periphery of the invasive tumor cell mass, or null expression or cytoplasmic expression. Now the question is, do we have to test all squamous cell carcinomas that we see in our routine practice to be able to differentiate HPV-independent versus HPV-associated tumors? In our paper, we have proposed that at least cases that are diagnosed over the age of 60 years. ICCR 2022 recommends this as an essential criteria, and WHO 2026, which will be published probably next year, probably will recommend this as an essential criteria. But it's also depending on how much money you have to spend. And, at the end, it's just, its HPV status matter? Do we really need to differentiate between the two categories, and why? And if you think of the management, NCCN guidelines suggest that surgical management should be different only for gastric type and the cervical adenocarcinomas at this point. We have a couple of studies like this, Turco et al. Published in 2022, which demonstrated that the response to the oncologic treatment is much worse in HPV-independent tumors comparing to HPV-associated tumors. And that particular study did include both squamous cell carcinomas and endocervical adenocarcinomas. So we know that these HPV-independent tumors do not respond to the oncologic treatment. But ESCO ASP guideline 2024 cites HPV status among other prognostic parameters. And to answer to this question, we have also published this study as an abstract, but it's in a review process now. It was presented at the ASP Congress in Wien this year. And in this study, we have collected over 600 patients with both squamous cell carcinomas and endocervical adenocarcinomas, HPV-associated and HPV-independent. And HPV-associated cancer had superior overall survival and recurrence-free survival compared to HPV-independent cervical cancers. And in multivariable analysis, HPV status remained significant for recurrence-free survival. So it does matter, and probably in the future, management guidelines and maybe even staging system will incorporate this prognostic parameter. Now, moving to the grading in squamous cell carcinomas, probably some of the oncologic institutes do not grade these tumors, and probably you are working in some of them, and you are not currently grading squamous cell carcinomas of the cervix. Some do grade. I do grade because my oncologists are asking me to grade. And if you grade squamous cell carcinomas, you can use either the broader grading system, taking into account presence of keratin pearls, tumor cell pleomorphism, and number of mitotic figures, or more recently with Jessinghouse grading system, taking into account number of buds, tumor cell buds, and size of buds. But there is a poor reproducibility among pathologists grading squamous cell carcinomas, and there is a limited predictive accuracy for squamous cell carcinoma. So about 2 years ago, we have proposed this new binary grading system, taking into account the stroma, either fibrous or myxoid stroma, which can be included together with either Broders or Jessinghouse grading system into this binary, low grade or high grade system. And this binary grading system is better when predicting overall survival, recurrence-free survival, and presence or absence of lymph node metastasis. And this is under a validation process now, and we are also testing other prognostic parameters that can go into this score, maybe a score system, and one of the parameters would be probably the percentage of the stroma. LVSI in cervical cancer, as you know, this is a parameter that has been very into focus for endometrial carcinoma, and there were numerous studies showing that this is a great prognostic parameter for endometrial carcinoma, and based on this studies, this is part of the 2023 FIGO staging system for endometrial carcinoma. But in cervical carcinoma, LVSI is not part of the FIGO staging system, is not yet quantified. However, NCCN guideline as well as the European guideline 2024 take this parameter into account when determining the clinical management for early stage tumors. We were interested to study this parameter in association with other clinical pathologic parameters in patients with cervical cancer, particularly with squamous cell carcinoma. Again, on this cohort of 670 cases from 10 different international centers that we have collected, we have demonstrated that the presence of LVSI is prognostically significant in both univariable and multivariable analysis for overall survival and progression-free survival. We were also interested to study whether the extensive LVSI has any prognostic significance compared to focal LVSI or absence of LVSI. And so we counted the LVSIs in all tumors that we have studied across all slides per case. So different approach from the one in endometrial cancer. We did not use immunohistochemistry to diagnose LVSI, and we found that patients who presented with extensive LVSI had worse overall survival and progression-free survival, as you can see in these curves, comparing to focal or no LVSI. And in this review paper that we have published this month, it's already online in International Journal of Gynecological Pathology, we suggest that the presence of LVSI should be documented in the pathology report, and also to start counting LVSI in cervical cancer, because this is probably a parameter that should be taken into account in the future. And we also recommend this to be reported. And this is something that is, in general, easy to be done without the use of immunohistochemistry. So this could be reported in the future, even in low resource settings. Moving to the last part of the presentation and talking about precursor lesions. Starting with HPV-associated squamous precursor lesions that, based on the last project published in 2012, are categorized into low-grade and high-grade squamous precursor lesions. With low-grade, that is considered by some pathologists not really true precursor lesion, because most of these cases do regress spontaneously, and extremely rare cases that are transforming into an invasive squamous cell carcinoma. Expanding the spectrum of L cells, this seborrheic keratosis-like lesion has entered into this category. It has been described by Dr. Karen Taylor from Australia in 2017 as this plaque-like architecture with involving both ectocervix and the endocervical glands. With cells that have this basaloid appearance, they do not present atypical features. Coelocytosis is absent. Sometimes you can find this basal palisading at the interface with adjacent stroma, and sometimes you can also detect these areas of larger cells with more abundant eosinophilic cytoplasm. And then moving to the real squamous precursor lesion that is HPV-associated, HSIL, which is divided into CIN2, in which atypical cells and mitotic figures are involving 2/3 of the epithelial thickness, and CIN3, in which the full thickness of the epithelium is involved by these atypical cells. Both of them are P16 block type positive. And as in the invasive tumors, P16 is a good surrogate marker for these high-risk HPV lesions, and it's positive in most of the cases of HSIL and a subset of cases of LSIL. And it is the only biomarker that is endorsed by the last project to help in differentiating HPV-associated lesions, LSIL versus HSIL, with the only comment here that last suggests to use the positivity for P16 to distinguish between the two categories, while in fact we are using the negativity of P16 as being helpful. There are some morphologic variants of HSIL, like thin HSIL with florid coelocytosis, with prominent surface keratin occurring in immature squamous metaplasia or pleomorphic, to be seen in the future if any of this has a significant prognostic importance. And only actually 3 years ago, in 2022, Dr. Regaur from Austria has described for the first time HPV-independent squamous cell carcinomas as precursor lesions. She presented in this paper 3 cases initially, all occurring at the transformation zone, and with a morphology that is either this kind of undifferentiated HSIL-like appearance, or differentiated VIN-like appearance, like the differentiated simplex squamous precursor lesion in the vulva. She mentioned that one case of HSIL-like lesion was P16 diffuse positive, and she also mentioned that some of them can be P53 aberrant. And in that study, in which we have collected 49 cases of HPV-independent squamous cell carcinomas, we found similar results. We found that 6 cases had this morphology of the VIN-like, with this eosinophilic appearance, with this elongated and anastomosing rete ridges, and atypia and mitotic figures confined to the basal and suprabasal layer, and they were all p53 aberrant. We found 11 cases that were with age seal-like morphology with loss of polarity, atypia, and mitotic figures involving the full thickness. Some of them were p53 abnormal and some of them were p53 wild type. And then we had 3 cases that had this VIN-like, verruciform acanthotic-like appearance. They were p53 wild type. They had this, I included this picture here. Most of them had this very exuberant architecture with acanthosis and minimal atypia and almost no mitotic figures. So the recommended terminology is CIN, cervical intraepithelial neoplasia, HPV independent to diagnose these lesions, and it would be included into the WHO 2026 as a separate entity. And to summarize the characteristics of these HPV-independent squamous precursor lesions comparing to HPV-associated ones, they are extremely rare at present. They occur in older patients. We don't know yet what are the risk factors, probably prolapse, probably pelvic irradiation, and probably some local irritating factors, maybe some inflammatory infiltrate, but we don't know yet. They can occur at the transformation zone, but also extend into the ectocervix or endocervical canal. The morphology is a spectrum, as I have described. We don't know much about the etiology at present. Immunostains P16 are P16 negative, patchy or completely negative, but sometimes they can be not block, non-block, but diffuse P16 positive, and they can be either P53 wild type or P53 abnormal, aberrant. We don't know much about the molecular basis. We are studying this right now. Screening and follow-up is going to be based on cytology and colposcopy because the HPV test is not going to help us. We don't know much about what is the time for progression to a squamous cell carcinoma, invasive squamous cell carcinoma, but apparently they do develop much faster than an HPV-associated squamous precursor lesion into an invasive component. And regarding the treatment, excision ablation with negative margin is probably the recommended treatment. And this slide actually synthesizes what I have told you so far, that the squamous epithelium of the uterine cervix can be exposed to an HPV high-risk infection. So it can develop an HSIL, P16 block type, P53 wild type squamous precursor lesion, HPV associated, which can transform into an invasive component. And this is a much more frequent scenario than something like chronic irritation or other local factors, which can, through a P53 mutation or IK3CA mutation, transform into an HPV-independent squamous precursor lesion, which can be either P53 abnormal or P53 wild type. I have included here a list of differential diagnoses. As you can see, P53 is going to help us to differentiate between these squamous precursor lesions and benign lesions, including inflammation, and probably P16 and HPV testing are going to help us to differentiate between HPV-independent and HPV-associated squamous precursor lesions. And then also the HPV testing can help us to differentiate between this VIN-like morphology and benign tumors like papillomas or condylomas, together with the presence of coilocytes. And we'll finish with this recommendations, because again, now pathologists are asking us, so how are we going to do in the future? Which cases to test? Well, basically, we should probably test all cases that we find in patients over the age of 60. Because from the age of 60, we have more and more HPV-independent squamous precursor lesions. Under the age of 60, they are rare. And then even before the age of 60, any biopsy that has this DVIN or VAVN-like morphology, or any biopsy that has an HSIL morphology, but it's P16 negative or it's HPV negative, or any case that has a discordance between the clinical features and the histology. And with this, thank you very much for your attention. I have included this picture here that I found in my laptop that is, I think, 10 years old now. It was taken in Belgrade during the European Society Congress. And as you can see here, Dr. Plotkin is next to me. There is Dr. Nucci, Boyana, Bill, Dr. Blake, Dr. Soslow, Katrin, and Sarit from Israel. Thank you very much for your attention.
Thanks so much, Simona. That was wonderful. I think, as you know, Simona, our group here that attends, they're from all over the world, and they practice in all sorts of different situations and have different experience levels. So I think this concept of this HPV independent squamous, group of lesions in the cervix is probably something quite new to a lot of people. So what a great introduction for all of us. There is one specific question for you, which I think this is very reasonable, and you alluded to the implications for follow-up, but this question is about implications for early diagnosis, and that is, as you know, many jurisdictions have or will be transitioning to HPV screening only, and that kind of cytological component will be removed. And so the question is, how are we going to go about identifying these cases in the early context if they're not HPV associated?
Yeah, this is a great question, and I'm really afraid of this question, because probably we're going to be asked many, many times in the future, what are we going to do? And I know that US and probably Canada also starts with HPV testing in your national screening programs. We don't. So for us, it's easier, but those ones who start with the HPV testing is going to be hard. Because it's only going to be the morphology of your biopsy or cytology. We don't know yet about the cytology. How does it look like? But it's probably the biopsy and its morphology that is going to tell you, together with the age of the patient, that something is wrong. Otherwise, I don't think that you are going to find these cases in a screening program, because all the cases that are negative will probably not be further tested, right? So this is going to be a problem, and we should actually try to convince national administration and people running these programs that they should change somehow and at least co-test HPV and cytology, because probably on cytology we're going to find some changes, even that case is going to be HPV negative. So that's my belief, but I'm not sure, and I actually at this point we don't know how it's going to evolve. All we can say is just we have to recommend people to be very careful, have an open mind, try to read as much as possible about this new finding. We are not familiar with this new lesions. We don't really know what to do. Probably like 20 years ago, I did mistakes thinking that this VA VIN-like morphology. Probably I have diagnosed as a, I don't know, papilloma or something like that. But again, I think that some of them really evolve very fast into an invasive component. So put them together will tell us more in the future. But regarding the screening, I don't know. And I don't know how happy all this administration is going to be to change somehow in the future.
Now, acknowledging that this is a rare phenomenon, or at least it seems like it, maybe in the coming decades it'll become more common. But
yeah, I think it's going to become more common because the vaccine, the HPV vaccine, is going to decrease the incidence of the HPV-associated lesions. So it will probably see more cases of HPV-independent ones, right?
Yeah, absolutely. So even though this is rare, at least right now, I think some people might be wondering, and you acknowledge maybe a couple decades ago I've missed this and such. People might be wondering, oh gosh, how am I supposed to make this diagnosis? And acknowledging again that they can be aggressive, they can transform rapidly, etc. What are your kind of perhaps top tips for people to kind of keep them safe and recognize these things in small specimens, particularly?
Every time you have a specimen that has a very particular morphology that reminds you of a vulvar squamous precursor lesion, try to do P16 and HPV and P53. Every time there is no correlation between the clinical features and the morphology, again, try to see why not. Every time the clinician tells you that there was nothing 1 year ago and now she presents with a lesion that has grown very fast, try to figure out why is that. And then every time the patient is over the age of 60, I would do these markers, even if it's an age cell morphology. About 20% of cases that are invasive squamous cell carcinomas over the age of 60 are HPV independent. So the more the age is increasing, the incidence of HPV independent squamous cell carcinomas is also increasing. So over the age of 60, we are going probably to find more cases. So the age is also very important.
Could you remind us of the expected patterns for P16 as the most common one? But and the other thing is, I think P53, that's going to be very foreign for a number of people in the assessment of cervical specimens. And you said, what we can do is the best that we can do and use the kind of vulvar patterns. But could you remind us of what you look for, particularly with P16 and also with P53?
Yeah, so for P16, for HPV-associated lesions, it has to be block type, meaning that you should see positivity in almost all cells, including nuclear and cytoplasmic positivity. You should not see diffuse P16, but in that diffuse positivity, you can find group of cells that are positive, and then in between you find 2 or 3 other cells that are negative, which we usually call the piano key pattern. You should see cell after cell that is positive, strong and diffuse P16 positive. All cases that are P16 non-block, as we say, or negative, are cases that are completely P16 negative, so you don't see any stain, or you see patchy. You see, some cells that are positive, and then other cells in between that are negative. For the P53, as I mentioned, we don't have criteria to interpret the stain in cervical pathology, so that's why we have looked at the criteria in the vulvar pathology. And according to those criteria, every case that is P53 aberrant is going to be either basal and suprabasal layer diffuse positive, or completely negative, or just cytoplasmic positivity. Again, cases in which you see like patchy, some cells are positive and some cells are negative, is going to be P53 wild type.
There is a question, perhaps this will be the last question, and then we'll give you a break and move on to the cases, unless Anna wants to join in as well. There's a question about the terminology for these HPV-independent precursor lesions and what you would recommend or what you see coming. Is DVIN like an appropriate diagnostic term to use, or VA-VIN like, or what would you recommend?
Yeah, so the recommendation is to use CIN HPV independent, so cervical intraepithelial neoplasia HPV independent, and this is going to be included in the next classification, WHO classification. This DVIN or VA-VN morphology, just use it in your comment. Don't use it as a diagnosis, because you're going to confuse the clinicians anyway, but don't confuse them even more. But if you use it in a comment, just describing the lesion, you'd probably give more information on that particular lesion to the other pathologists or clinicians, or even when it will recur or transform into an invasive component. Because if the previous lesion, if the precursor lesion was a VA-VAN-like lesion, probably verruciform acanthotic lesion, you will probably know already when you look at the invasive component that this is going to be probably a P16 negative and a P53 wild type invasive component. So we already have some clues about the precursor lesion, not only that it was HPV independent. So I do recommend to include this in a comment as a description, but the final diagnosis should be using this terminology, CIN HPV independent. Yeah. But I have to mention also that it might probably change in the future. The more information we are going to get about these lesions can change it.
Yeah, absolutely. Anna, anything else?
Yeah. So thanks, Simona. That was wonderful. And you know what, when we started this community of interest more than 10 years ago, one of the cases that was presented by one of our community friends was actually an HPV-independent H cell. And at the time, everybody questioned themselves, is it H cell? And was amongst us, I think a lot of people didn't believe in this entity. So I very well still remember this case from Dr. Amir Samani, who presented it back then. One question to you, since you have also memorial clinicians on your paper, I understand the prognostic value, but what is the predictive value? Once you sign out this HPV-independent lesion, what would your clinician do differently, or maybe clinicians from Memorial?
I don't know about the clinicians at the Memorial Slow Kettering. In my institution, they don't do anything else. Even if it's an HPV-associated lesion, the treatment is the same, the management is the same, but they are aware now of the fact that these lesions are going to be more aggressive, and there is no response to treatment. And I see now, now that I know, I see more and more cases. I don't see many cases, but I see, let's say, like one case every 2 or 3 months. And when I see this HPV-independent squamous cell carcinomas, they are very aggressive. There was oncologic treatment before, and they did not respond to that oncologic treatment. So the thing is that this is a prognostic and also a predictive factor, being HPV independent, and probably in the future we should change the approach, the oncologic approach, but how, I don't know yet, and we don't have the answer yet. We have to see if we can find any alternative management approach for these cases that are not going to respond. These patients are going to die, probably.
Thanks. And maybe very quick, Simona, if you can touch base on counting LVSI spaces in that situation? Because it's always source of confusion and people do it very differently.
Yeah, so when we have run this project like 3 years ago, we have started also to count the LVSI. And at that time, there was no criteria on how to count it in a cervical pathology setting. So we thought, oh, let's look what they did for the endometrial carcinoma. And basically, we have started to count LVSI in squamous cell carcinomas using the WHO criteria for the endometrial carcinoma. That's why our approach is less than 5 or more than 5 spaces involved by LVSI per case, but we did not count them on one slide as they do in the endometrial carcinoma. Because we had all slides available in each tumor, and we had from 12 slides, 10 to 12 slides, up to 24 slides per case. We have counted them across all slides. So this counting has taken into account all LVSIs that we found in every case. And we found differences in survival. And that's why I think that is something that we should really concentrate on in the future. And maybe together with HPV status, we'll, get into management guidelines and probably also staging system, because now the staging system is evolving in GYN pathology, and we have this new staging system for endometrial cancer. So probably they are somehow ready, the FIDO is somehow ready to change the next staging system for the cervical cancer, also including some prognostic parameters. So I think that the SILVA pattern of invasion together with HPV and LVSI would probably go into it. But we're just hoping this and studying this at this point.
I think we should start with cases so people will get involved.
Thanks
again,
Simona. We'll give you a break, Simona, and we'll have Dr. Lisa Hahn. I see she's coming online here, and she'll share her case. Dr. Lisa Hahn is a gynecological pathologist at Lake Ridge Health in Oshawa, Ontario, which is actually where Anna works.
I'm gonna go right into it. So my case is a 32-year-old G3P0 female who at around 35 weeks gestation delivered a stillborn with cord complications. 2 months later, she came to the ED with vaginal bleeding and a positive urine pregnancy test. Her ultrasound showed no intrauterine gestational sac, just some retained products, and so she was sent home with clinician tracking her HCG. 2 weeks later, June 8th, she returned to the ED reporting sudden onset right chest pain, abdominal pain, and shortness of breath and blurry vision, and so she was admitted. Around this time, I received her placenta for histologic evaluation. And on the 17th, the surgeon calls me with great suspicions for gestational trophoblastic disease, given the rapidly increasing beta HCG and clinical findings. And because I had not seen evidence of gestational trophoblastic disease in my original sections, we decided to submit additional sections of placenta. A few days later, she was started on multi-agent chemotherapy. So her inpatient CT showed subpleural masses, brain masses, and 2 splenic nodules, which probably accounted for her shortness of breath, blurry vision, and abdominal pain. Gross examination of the placenta showed firm nodular tan areas, as well as areas of hemorrhage, and it was around 700 grams placenta. And the original histologic sections showed non-specific findings such as placental infarcts shown here, intervillous thrombohematomas not shown here, as well as patchy areas of hypovascular edematous chorionic villi. And then we submitted additional sections. In one slide, and only in one slide, at the edge, there was a 8 millimeter focal area of trophoblastic proliferation with syncytial growth, marked cytologic atypia, including nucleomegaly, prominent nucleoli, and associated necrosis, as well as high mitotic activity. Immunohistochemical staining show that the lesional atypical cells are positive for GATA3, focal weak positive for P63, patchy positive for SAL4, as well as with had a very high Ki67 proliferation index compared to the background placenta. And then unsurprisingly, beta HCG is positive both in the lesional neoplastic cells as well as the background placenta. So a diagnosis of intraplacental choriocarcinoma was made. This entity is thought to be under-recognized and under-diagnosed, occurring in 1 in 50,000 to 160,000 pregnancies. 50% of them occurring after term pregnancies, which can be completely normal. 50% occur after gestational events such as molar pregnancy and ectopic pregnancies. Almost half of patients present with metastasis, and interestingly, the size of the IPC does not predict the metastatic behavior. Clinicians use beta HCG levels for diagnosis, evaluation of chemotherapy response, as well as screening for recurrences. And fortunately, over 80% of these patients achieve complete remission with chemo, even when metastatic, as with our case. Surgery was only performed in selected cases listed here. So grossly, these entities can be very subtle and can be mistaken for placental infarct. It can be dark red solid friable areas of hemorrhage and necrosis. However, 40% of cases, as in with my case, the cut surface can be grossly normal. Microscopically, this is a triphasic morphology showing sheets of markedly atypical syncytial trophoblasts, cytotrophoblasts, and intermediate trophoblasts in various proportions. It can have infiltrated destructive growth pattern with high mitotic activity, background necrosis, and hemorrhage. And notably, the absence of villi dogma of classical choriocarcinoma does not apply with IPCs and choriocarcinomas arising from molar villi. Immunohistochemically, all these neoplastic cells should be positive for pancytokeratin A1, A3, CK7 with high mitotic activity, high Ki67 proliferation index. And depending on the proportion of the other three components, you can have different immunohistochemical profiles. If there's syncytial trophoblast presence, beta HCG and inhibin would be positive. However, as we saw in this context, beta HCG is not too helpful. Cytotrophoblasts are positive for SAL4, beta-catenin, and GATA3, whereas intermediate trophoblasts can be positive for P63, HPL, inhibin, GATA3, and SAL4. And a recent paper by Tricourt et al. Showed the utility of using SAL4 immunostaining in differentiating choriocarcinoma versus trophoblastic proliferation in molar and non-molar gestational lesions. So in diffuse SAL4 expression was seen in greater than 10% of cytotrophoblasts, intermediate trophoblasts with clustered nuclear positivity, and that favors choriocarcinoma over trophoblastic proliferation seen in non-choriocarcinoma lesions, which showed either 0 or very focal SAL4 expression. So key points is that this can be a clinical diagnosis based on beta HCG and imaging. So it's important that the clinicians knows to start chemotherapy as it has a very high cure rate. And it's important to sample the specimen thoroughly because as we know, even very small lesions can be associated with metastasis. This is a triphasic tumor, which can have different proportions of the three components. And so it's important to use multiple immunohistochemical markers in your workup. Thank you.
Wow. That's a terrifying one. I'll ask if Simona is available, perhaps there she is. I'll ask for her thoughts. What do you think, Simona?
Well, I'm not doing placental pathology, fortunately, so I don't see many of these cases, almost none in my practice. It's fascinating.
Yeah.
But I have no experience with them.
Yeah, I think as Lisa said, that what we're all taught during our training, oh, this is not possible, and then it is possible.
Yeah.
It is possible. And I guess I think the one thing, Lisa, as you said, that is kind of just comforting is that this patient, whether you found that or not, this patient will be treated in the exact same way that she was treated. So that's the one comforting thing in this very, very disturbing situation. But what an amazing case, Lisa. Thank you so much for sharing.
Yeah, absolutely. And like I said, almost 50% of these present with metastasis, and the rising beta HCG levels really prompt the clinicians to act even before we histologically have a diagnosis.
Yeah.
The problem may be with placentas in general. We all practice in understaffed environments, so placentas get piled in our grossing rooms, and a lot of the lesions we really don't get to them on time. So that's something, unfortunately, like every institution I worked for, it's at least half a year backlog on placentas. And then it's also backlog. Lisa is amazing pathologist, nothing backlogs in her office. That's why she's on top of things, but
That's
everyone else is
Yeah.
quite different.
I just see Dr. Wolski is joining us from Colorado, I believe. She just said she's had something similar, totally unexpected. They're also screening the infant as well, which I guess is an important
consideration.
Yeah. All right, cool. Awesome. Thanks again, Lisa. Perhaps we'll go on to Simona's first case.
Okay. So this is case number 1, and this is a polypoid lesion in the cervix that was found in a postmenopausal patient. The patient was 63 years old when she was diagnosed with this polypoid lesion of 1.5 centimeter diameter. And as you can see at low power magnification, it is a very busy architecture with tubular structures as well as some cribriform areas and very little intervening stroma in between. If we go higher power, these structures are lined by columnar cells with intracytoplasmic mucin, with some areas with uniform nuclei. However, other areas have this pleomorphic nuclei. There were inflammatory infiltrate in some of the glandular lumina, and some other areas presented with squamous metaplasia. And again, some areas had pleomorphic nuclei and many mitotic figures. So the question here is this a benign lesion or is this a malignant lesion? And if it's malignant, is this endocervical origin or endometrial origin? And this is especially important in a setting of a biopsy or a curettage, but also in this setting of a polypoid lesion. So we did markers. Cytokeratin 7 was positive, cytokeratin 19 was positive, ER was positive but weak, PR was negative, CDX2 was negative, P16 was negative, P53 was wild type, and the best marker that we did was actually P63, which highlighted the reserve cells that are surrounding all these tubular and cribriform areas. So the final diagnosis was microglandular hyperplasia, which is a benign lesion, and which is characterizing young women, usually. Young women that are either during gestation or are exposed to hormones. But it can occur in older women as well. And you're going to find this lesion usually incidental. It's a microscopic finding, but sometimes, as the case that I have presented, it can form polypoid structures. Going at high power magnification, these areas are usually very crowded architecturally, and all these tubular structures and cribriform areas are lined by cuboidal or columnar cells with variable amount of mucin. And the cytoplasm can be clear or eosinophilic or vacuolated, and the presence of inflammatory infiltrate and squamous metaplasia is also helpful. And in general, these cases do not present with atypical nuclei and mitotic figures are sparse. However, some cases, as the case I've shown you, can have nuclear pleomorphism and many mitotic figures. The main differential diagnosis, especially in a postmenopausal woman and when it forms like a polypoid lesion, is with endometrial carcinoma. And there is this let's say, morphology, the microglandular morphology in an endometrioid carcinoma. And if you look at these two pictures, one is microglandular hyperplasia and one is endometrioid adenocarcinoma with microglandular features, they look very much alike. They have this morphology that is very, very similar. They both have proliferation of glands with variable size and shape, with cribriform areas that can be present. They are both lined by cells with mucin. They both have this polymorphonuclear infiltrate within the lumina, and squamous metaplasia can be present in both lesions, and atypia and mitotic figures can be also present in both lesions. So to differentiate between the two lesions, keep in mind that endometrioid carcinoma is a tumor that is developing usually in postmenopausal patients which have a history of exogenous hormonal treatment. And it is also important that when you look at the microscope to see a continuity of this tubular structures and cribriform areas with normal endometrial glands within the same fragment of biopsy or curettage. This is going to be in favor of an endometrioid adenocarcinoma. Also favoring endometrioid carcinoma are going to be presence of atypia, mitotic figures, and stromal foamy macrophages. And the immunohistochemistry is not going to be very helpful because most of the markers do overlap, but we have two markers that can really help. And one is P63 or P40, which highlights the presence of reserve cells in microglandular hyperplasia, and the other one is P10. And in this study of Dr. Scala that was published in 2022, the authors included 25 cases of endometrial carcinoma and 26 cases with microglandular hyperplasia. And cases with endometrial carcinoma did present microglandular features, and they used P63 and P10 to differentiate and really demonstrated that cases of endometrioid adenocarcinoma with microglandular features are P63 negative and P10 negative. So these two markers are going to be extremely helpful to differentiate between those two lesions. You might also include in your differential diagnosis usual type endocervical adenocarcinoma HPV associated, but this tumor forms a mass usually and occurs in younger women. And if you look at the microscope, you can easily detect mitotic figures and apoptotic bodies within this cribriform and glandular structures. P16 is going to be block type, as in this picture that I have included here. HPV, high risk by ISH, is going to be positive, and P63 is going to be completely negative. And I have also included this invasive stratified mucinous carcinoma, which is a tumor I'm going to talk about later on because I have a different case, but it is a tumor that is HPV associated, and sometimes it can also mimic the microglandular hyperplasia. As you can see in this picture here, it is with a similar morphology. But the peripheral palisade is helpful. That is characteristic for this invasive stratified mucin-producing carcinoma. Remember that P63 can be positive in this particular tumor at the periphery of the tumor cell mass. So P63 is not going to help you very much, but this tumor being HPV associated is P16 block type positive and high risk HPV by ISH positive. So again, to summarize, differential diagnosis between microglandular hyperplasia and other malignant tumors, especially usual type endocervical adenocarcinoma or invasive SMILE, to perform always a panel of markers, including P63 or P40 and P16. And if you are not really able to provide definitive diagnosis, just include complex florid microglandular proliferation in your diagnosis and obtain additional tissue. And ask your clinician about any other information that can be provided for that patient. Clinical examination, imaging, the HPV status, and base your diagnosis on clinical and pathological correlation. Thank you.
Awesome. Thank you. Very, very practical case, very common situation, I think, for us that practice oncologic gynae pathology, especially from a consultation perspective. I think this is a common question that people that are dealing with this stuff have. Is this nothing, or is this something serious? I think I do the same thing. I love P10. I know one of my colleagues is on the call. I think she loves P10 too. We employ it in this particular scenario frequently. I like using, P63 as well in this situation. Or I guess I'll ask you, could you reiterate the importance of the kind of clinical picture in these scenarios? Because I think often that gives you most of the answer, and then the other stuff just kind of helps you at the end. But could you reiterate for everybody the kind of clinical features that would kind of guide you one way or the other?
So microglandular hyperplasia is going to be a lesion that develops in young patients usually, first of all. So whenever you see an older patient, is probably not microglandular hyperplasia, but no. The second is that this is usually an incidental finding. So we can look at the microscope for a hysterectomy specimen that was removed from something else. And we can see small foci of microglandular hyperplasia when we examine the cervix. But sometimes we just get the curettage. And when we look at the curettage, we can see areas that look busy. And those particular areas are very important to focus on. So the age of the patient is very important. Any clinical features that can help, like is this a lesion that the clinician has seen? Are the imaging helpful, telling you that this is a tumor somewhere? Is the cervix involved? Is the endometrium involved? Has the patient had received any hormonal treatment, or if the patient is young, is the patient pregnant or was pregnant recently? So these are very helpful to diagnose this lesion. And then to me, the best marker actually is not P10, because the P10 is not working very well in my lab. Is P63, because P63 is going to highlight all those reserve cells in microglandular hyperplasia, like a rim of cells around all these structures, while in endometrioid adenocarcinoma, they are usually absent, completely absent, or if they are positive only in squamous metaplasia areas. So they are concentrated in some foci, but not all over the lesion, like I showed you.
Yeah, absolutely. What a great case. Thank you, Simona. Perhaps we'll move on to next person, which there she is, Dr. Buska, joining us from Ottawa.
Hi, Anjelica. Thank you for having me. Excellent. Thank you very much. I wanted to share with you today a very interesting case that I got last year as a consult. I learned a lot from this case, so hopefully you'll find it interesting. I received a hysterectomy specimen in an older lady, 76-year-old, for what was thought to be a uterine fibroid. Grossly, we had a 10-centimeter myometrial nodule intramural that looked unremarkable grossly. The cervix, the next there were unremarkable. And this is what the tumor looked like on microscopy. It had very high-grade nuclear atypia, lots of necrosis. We have here in the left upper corner. The vascular pattern was very unusual for me. It had these thin-walled branching vessels. This tumor came with the presumed diagnosis of leiomyosarcoma from my community pathologist colleague. And I must say this would fit very well with the leiomyosarcoma for sure. This is more, I'm trying to get rid of this. Yes. These are more additional sections of what the tumor looked like. Again, on higher power, we can appreciate the extreme nuclear atypia, pleomorphic nuclei, multinucleation. Everywhere, again, this particular vascular pattern of branching vessels, very mitotically active, up to 30 mitoses per 10 high power fields. Interestingly, other parts of the tumor, although a minority, had a different morphology. They looked more fascicular. The nuclear atypia was mild to moderate here. And again, throughout, the vessels were not the typical thick-walled vessels that we would expect in a smooth muscle lesion. And focally, you had this pattern of the tumor cells irradiating from the lumen of the vessel. So this brought up the differential of either a leiomyosarcoma because of the predominant epithelioid morphology and epithelioid leiomyosarcoma versus a PCOMA. So I performed immunohistochemistry. Not surprisingly, smooth muscle markers were positive. This is an area of the higher grade morphology, staining diffusely with caldesmin. Desmin was also diffusely positive. And I performed immunohistochemistry for neurogenic markers. We have S100, HMB45, and melan A available in our lab. S100 was negative. HMB45 showed some staining, but it was definitely not diffuse, and melan A was negative. So I was kind of still working in the diagnosis of PCOMA, but I didn't have enough positivity to be fully confident. I sent it for MITF, which is another marker typically positive in PCOMAs, and this also showed some positivity, but definitely not diffuse. It was more than 50%. Again, the morphology, it was mostly in the areas that were high-grade epithelioid looking. Other markers performed, you have a summary here. ALK, STAT6 were negative, FH was retained. This particular pattern of the vessels can be seen in FH-deficient tumors, including FH-deficient leiomyosarcomas, but it was retained in this particular tumor. ERPR was negative in these high-grade areas, but positive in the low-grade fascicular component. That prompted me to send it for molecular testing. And on molecular, this lesion had a TSC1 and a P53 pathogenic mutation. I had an idea about the P53 abnormality even on the H&E. This is an area that shows nicely that the high-grade morphology, the epithelioid component, had areas of P53 overexpression. And you can nicely see here the transition towards the lower grade fascicular areas that were P53 wild type. But having the TSC1 mutation, having the smooth muscle and the neurogenic marker, my final diagnosis for this was a uterine PCOMA. Again, size-wise, it was 10 centimeters. It was limited to the uterus. There was no LVI. The margins were negative. There are malignant features associated with this lesion, and I'm going to talk about what those are. In terms of follow-up, the patient was referred to medical oncology, and they decided on no other treatment, just to follow if there's any recurrence in the future. So far, it's been 1 year, and she is disease-free. A few words on PCOMAs. I mentioned that these come often in the differential diagnosis of smooth muscle tumors, especially for the more epithelioid ones. And typically, they are defined by co-expression of melanocytic and smooth muscle markers. Molecularly, they are characterized by either TSC1 or TSC2 mutations or TFE3 rearrangements, and these are typically mutually exclusive. There is an association with tuberous sclerosis, typically in younger patients when there's multiple lesions. And why is it important to recognize this entity? It is important because they are particularly susceptible to mTOR inhibitors. So advanced or metastatic cases, these patients would typically be treated not with the typical chemotherapy regimens, but with mTOR inhibitors. We know that some of these behave well, and we know that some of these have malignant features. Dr. Bennett has done quite a bit of work in this area, and we know that if you have more than 3 features from the list that I've included here, so size, severe nuclear atypia, necrosis, vascular invasion, or increased mitotic activity, then at least 3 features would predict malignant behavior. And I would draw your attention to the fact that the mitotic activity count is particularly low in these lesions. And interestingly, in her paper, she also showed that the cases that had malignant behavior also had associated p53 mutations, which was the case with the tumor that I had. So I was quite confident in calling this a PICOMA with malignant features based on the fact that this was a 10 centimeter mass, there was severe nuclear atypia, there was necrosis, and it was a very increased mitotic activity. So learning points for me, even when you think you are there in terms of diagnosis, if there's anything that doesn't totally make sense, and for me it was the vessels in this particular case, consider doing additional sections, consider a diagnosis of PICOMA, even in cases that are very malignant looking, very high-grade nuclear atypia. And if the IHC doesn't help take you there entirely, then consider doing molecular testing. And in this case, everything taken together led me to the diagnosis of PICOMA. Thank you. That is all I have.
Awesome. Thank you so much. What a difficult case. I'll ask Dr. Stolnicu what she thinks.
I would like to ask Aurelia, what would you do in a lab that does not have genetic testing? How would you diagnose this tumor, and how much positivity would you accept for HMB45 and melan A to call it a PICOMA without any genetic testing? Because this is
thank you, Dr. Stolnicu. These are great questions. Great questions. Actually, we don't have molecular testing in our lab. We had to send it to our friends in Toronto for the sarcoma panel. We do have a sarcoma panel that is limited, that does not have the TFE3 rearrangement. So I wanted to make sure that all options are covered. Again, we don't know from the literature. The specialists do not agree about how much HMB45 positivity is acceptable in leiomyomas or leiomyosarcomas. I would say if there is diffuse staining, over 50%, and Dr. Bennett proposes that if you have a tumor where the morphology fits and you have melanocytic markers, at least 2 melanocytic markers with diffuse positivity, meaning over 50%, you can call it favoring a PICOMA even in the absence of molecular confirmation. What prompted me in this case to seek the molecular confirmation was that I thought the morphology fit really well, but the PICOMA markers were not as diffuse as we would like them to be. And yes, it becomes problematic when in cases where you have some melanocytic marker expression, the testing is negative, the molecular testing is negative, but the morphology is great, everything fits. And to answer your question practically, I had a similar situation that I could not figure out, and I could not favor one versus the other, and I actually sent it to Dr. Bennett. It was a case where the patient was actually young, and depending on what we called it, they would consider hysterectomy versus not. And yes, at the end of the day, sometimes you really cannot make that call. And I think making a descriptive diagnosis and mentioning the differentials, if a hysterectomy comes, that's great, you can take it further. But sometimes giving a descriptive diagnosis, I think it's perfectly acceptable. And referring to these potential malignant behavior parameters is also useful. Because at the end of the day, if you have something that is completely bland and no proliferation, I think whether you call it a leiomyoma or a PIComa, it may not make such a great difference from a clinical perspective. But yes, definitely it's a common and difficult scenario.
And one more question. Do you think that diffuse positivity versus patchy positivity is related to the tumor differentiation? Because I've seen benign picomas that were diffuse positive for all the markers, while in this kind of aggressive malignant ones, they tend to be less positive. Do you think it's related to the grading or something like that?
It could be. I haven't seen that many myself to be able to, make that assessment from my experience. But I also find that the positivity is also linked to the morphology. The more epithelioid areas tend to be the ones that are more that are staining more by IHC, and the more spindled ones tend to stain less. So when I choose the blocks, I typically stain multiple blocks, and I focus on the areas that are a bit more epithelioid. But yes, in really higher grade ones, I would expect that some of the less staining areas would be because of the so-called high grade differentiation issues. But I find that the focusing on the epithelioid versus the spindle typically works well.
Yeah, Aurelia, there was a question about that in the chat that Simona's question covered. Let me just ask one more thing to everybody on the screen here. Do you agree with this statement that I think this is the reason why I'm asking is I think this is helpful for people that are seeing stuff in their community practice and such, that the presence of particularly HMB45, but any one of these melanocytic markers in a little bit of the tumor in kind of a sporadic areas and such, that's not sufficient to make the diagnosis of PIComa. Do you agree with that?
Correct. And to be honest, at the beginning, I used to stain a lot and then hope it's negative and just move on. But like these days, I only stain areas or tumors that I feel that the morphology is really good. Because yes, what are you going to do with like scattered a bit of HMB45 here and there? And yes, in those cases, I would accept it that it is just a barren staining and not enough to call it a PIComa.
You agree with that, Simona?
Totally.
Yeah. I think we've become a little bit more comfortable with accepting that there's a little bit of HMB45 and stuff in smooth muscle tumors and such that yes. that by itself is certainly not sufficient. Okay, wonderful. Thanks so much, Aurelia. Pleasure to see you. Thanks again. And we'll move on to Dr. Stolnicu again.
So this is case number 2. This is a polypoid lesion again in the cervix that was diagnosed in a patient, 39-year-old, which has had breast cancer like 3 or 4 years before this polypoid cervical lesion was detected. And this is a low power magnification of this cervical polyp. And you can recognize some endocervical glands, but you can also see that some areas are more hypercellular and some other areas are hypocellular. And if we go to the hypercellular areas at high power magnification, you can recognize that this gland and the stroma surrounding the glands are of endometrioid type of glands and stroma. And in some areas, these glands look totally benign, But in some other areas, they start to look atypical, like here, comparing to the benign glands that have this blue, dark blue epithelium. These atypical glands are lined by these columnar cells that are more pink color. And some other areas, higher power magnification, in which you can see that these glands are lined by mucin-depleted cells with this kind of pink cytoplasm, pleomorphic nuclei, and no mitotic figures and apoptotic bodies are present or seen at scanning magnification. In contrast, these cells present cilia. So we were curious to see if these glands are estrogen and progesterone receptor positive, and they were all these endometrioid type of glands, benign and atypical, were positive for estrogen and progesterone receptor. They were patchy positive for P16. In other words, they were negative for P16. This is the patchy morphology. When you look at the P16 and you see some cells that are positive, but some other cells in between that are negative, this is negative P16. We did also Vimentin that was positive, BCL2 was positive. We did high-risk HPV and was negative. And we also did some breast markers just to exclude any link to the breast lesion that she has had, and they were all negative. P53 was wild type. So we have diagnosed this as in situ adenocarcinoma of the cervix of endometrioid type, HPV independent. And as you know, the IECC classification and the WHO 2020 classification do recommend to use this diagnosis of endometrioid type endocervical adenocarcinoma in situ or invasive with caution. And this is because in the old studies, this was a very frequent diagnosis in the cervix based on the fact that most of the cases that were mucin depleted of endocervical adenocarcinomas were called endometrioid type only because of this mucin depletion. But we know now that endometrioid type endocervical adenocarcinoma is a very rare tumor. Actually, it represents less than 1% of endocervical adenocarcinomas, and it usually develops from cervical endometriosis. In other words, you can see or you can detect areas of cervical endometriosis at the periphery of the tumor, or as in this case, associated with in situ adenocarcinoma. And the tumor, if it's invasive, has to have conformatory endometrioid features, not only this endometrioid type of morphology and the background of cervical endometriosis, but also squamous metaplasia. It has to be estrogen receptor diffuse positive, P16 negative, and HPV negative by ISH. And the mimic here is tubal metaplasia, which is a much more frequent lesion that we can encounter in cervical pathology. And this is an example of tubal metaplasia, and you can see areas of endocervical glands that are indicated by this green arrow, and these endocervical glands are much more pale in color comparing to this dark blue glands that are of tubal metaplasia. So they look dark blue at low power magnification, and sometimes they also look it's kind of funny and angulated, especially after a biopsy or a cone. So after surgery or after a procedure, of a diagnostic procedure, they can become a little bit angulated and funny looking. If you compare again to the normal endocervical epithelium, which is this kind of pale blue, tubal metaplasia is pink because the cells have this pink cytoplasm, and the nuclei are usually uniform. Mitotic figures are not present, but cilia are present. And the most problematic area is when there is a young patient with an early stage endocervical adenocarcinoma, and because of the fertility preservation, sometimes the surgeons do perform trachelectomy, and they shave the surgical margin and they send it to us in a frozen section. And in a frozen section is usually particularly difficult to differentiate tubular metaplasia from in situ adenocarcinoma, usual type, or endometrial, much more rare endometrioid type. And this is a picture taken from paper that Dr. Park from Memorial Sloan Kettering has published, in 2008, so ages before. But she has had cases that were very difficult to be diagnosed in a frozen section and were diagnosed in a frozen section as in situ adenocarcinoma. But then when they performed the Ki-67 index, as you can see here, the index was very low, showing us that they were actually benign lesions. So how to differentiate between tubal metaplasia and in situ adenocarcinoma? First of all, endometrioid type, which is an HPV independent. So the HPV test is going to be negative in both of them, is not going to help you. P16 is going to be negative in both of them, patchy, so is not going to help you. Fymentin is going to be positive, as well as estrogen and progesterone receptors in both of them. And markers for cilia, like BRAF, is going to be positive. So the Ki-67 index here becomes important because it's going to be high in situ adenocarcinoma endometrioid type, and usually low, less than 10% of cells in tubal metaplasia. And CA9, I'm going to show you a picture in a while, in which CA9 is a good marker to differentiate any benign lesion from any malignant, including endometrioid adenocarcinoma, endometrioid type, in situ or invasive. And then if you want to differentiate tubal metaplasia from in situ adenocarcinoma usual type, which is an HPV-associated lesion, then yes, here P16 can help you. It is diffuse block type positive in situ adenocarcinoma usual type, and usually patchy negative in tubal metaplasia. But be aware of the fact that sometimes this P16 in tubal metaplasia can be a little bit more diffuse positive. And then CA9 again is going to help you because it's positive in all malignant lesions, including usual type. Ki-67 is going to be helpful, is high in situ adenocarcinoma usual type, and Fymentin is negative. Sometimes it's positive, is not very helpful, but in most of the cases is negative. ERPR are usually negative in situ adenocarcinoma usual type. BRAF is negative, and of course HPV by H is positive. And these are two pictures of P16 patchy positivity in tubal metaplasia. On the left-hand side, it's really patchy. On the right-hand side, it's a little bit more, let's say, diffuse, but you still find cells in between these cells that are stained with P16. You can still find cells that are negative. There is no staining. So this is what we call the piano key appearance, in which you find positive cells and negative cells, showing you that this is P16 negative. And then CA9 is a great marker because it's going to be negative, as you can see here, in normal endocervical glands, and positive in all neoplastic glands, HPV-associated and HPV-independent. And then BRAF is, of course, targeting the BRAF mutation, but it's also a good marker because it will indicate all cells that have cilia. So the tubal metaplasia is going to be positive for BRAF, but so is going to be endometrioid type in situ adenocarcinoma. If you have any questions for case 2.
Simona, maybe I'll just ask you, because there's just two questions, similar vein, just about distinguishing, if you could reiterate morphologically and immunohistochemically how you would distinguish kind of tubal metaplasia and a tubal metaplasia that is very reactive versus a true endometrioid type AIS.
Well, tubal metaplasia usually does not have atypia. It's like a blend cytology, no mitotic figures, no apoptotic bodies. In situ adenocarcinoma endometrioid type does have atypia. It does not have mitotic figures and apoptotic bodies, but atypia is present. But also remember that in situ adenocarcinoma endometrioid type is an extremely rare event. So before making this diagnosis, really make sure that this is not reactive. And the only feature that you can use is the atypia, actually. A little bit of immunohistochemistry, but not much. If you have a CA9, is good, but if not, if you have Ki67, is good, but not other marker is going to help you. And the rarity of the lesion is going to be very helpful, actually, because as I said, this is a very, very rare scenario.
Okay, thank you.
Okay, shall we go on?
Yep, I think we'll do the next one because it's not dissimilar. And then
yeah, somehow related. Okay, so also related to this HPV-independent glandular precursor lesions, as you know, WHO classification 2020 divides now these lesions also into HPV-associated and HPV-independent. And at the time it was released, actually in 2020, we didn't know much about these glandular precursor lesions that are HPV-independent. So the previous case was an example of an HPV-independent glandular precursor lesion endometrioid type. And this case number 3 is also related to this HPV-independent status. So this is a case of a 14-year-old patient that presented with an abnormal pap smear. She was tested for HPV and the HPV test was negative. And a biopsy showed something. I have had no access to that biopsy, but I have received the cone. So this is the low power magnification of the cone biopsy. And as you can see here, you can identify the squamous ectocervical epithelium that has nothing, is normal. But beneath this, you see a proliferation of glands that are infiltrating the cervix and are associated with stromal desmoplasia. And going higher power, these glands are lined by cells which have large amount of clear cytoplasm, and the nuclei look atypical. They look hyperchromatic. Some of them look like hobnail protruding into the lumina, but again, no mitotic figures and apoptotic bodies at scanning magnification, and again, the presence of stromal desmoplasia surrounding this glands. So we thought that this is an infiltrative component of what we have called clear cell adenocarcinoma infiltrating the cervix. And there were some glands that were located beneath the squamous epithelium. And these glands were also lined by the same type of cells with hyperchromatic protruding into the lumina nuclei, clear cytoplasm, and no mitotic figure. So we thought that this is the in situ component probably. We have stained both components for napsin A, and napsin A was positive in both. Both components were negative for P16. Both components were negative for hormone receptors. Racemase was negative. CD10 was negative. We did a lot of other markers just to exclude some other lesions. They were all negative. P53 was wild type. We did some MMR staining and they were intact. Ki67 was approximately 40%. We have asked the patient and her mother about any hormonal therapy. She was not exposed to any previous hormonal therapy, and she was not exposed to intrauterine diethylstilbestrol. So the final diagnosis was on early stage, stage 1A1, FIGO 1A1, invasive clear cell carcinoma with an in situ component. And again, clear cell type adenocarcinoma of the cervix is rare. and is an HPV-independent invasive tumor that can occur after in utero exposure to diethylstilbestrol, but sometimes can also occur sporadic. But it usually does form a mass. As you can see in this picture here, it is usually a mass that is clinically visible and has a characteristic morphology of any other clear cell type adenocarcinoma in the endometrium or in the ovary, with solid papillary or tubulocystic architecture, with these cells that are lining the structures that have mostly clear cytoplasm, but sometimes eosinophilic cytoplasm or foamy cytoplasm, and with absence or rare mitotic figures and apoptotic bodies that indicates you that this is probably an HPV-independent lesion. And we have published this case as potential precursor lesion of clear cell type to clear cell invasive adenocarcinoma. And an alternative origin for these tumors is the atypical tuboendometrioid metaplasia described by Dr. Talia. And the mimicker here is area-stellar reaction. As you know, area-stellar reaction can occur in the endometrium, but can also occur in the cervix. But when it does occur, it is usually a microscopic reaction. If it's not associated with a polyp or something that is clinically visible, you are not going to see area-stellar reaction clinically or macroscopically. You are going to see a small microscopic foci like this one, in which endocervical glands are lined by this cells with clear, abundant cytoplasm, again, hyperchromatic nuclei, sometimes protruding into the lumina without mitotic figures and apoptotic bodies. And of course, to differentiate, especially on a biopsy or on a curettage, to differentiate between clear cell adenocarcinoma in situ or invasive and area-stellar reaction, the context is essential. As I said, area-stellar does not form a mass, does not have an infiltrative component, is usually not associated with solid or papillary areas. You see glands, mostly glands that are lined by these cells with clear or eosinophilic cytoplasm and hyperchromatic nuclei. And these areas are merging with normal endocervical glands like in this picture here. And immunohistochemistry, again, is not very useful because markers of clear cell differentiation are likely to be positive in both lesions. And as you can see here, estrogen receptor can be positive in area-stellar, but weak and focally. It's usually negative in clear cell carcinoma. Progesterone receptor negative in both. Napsin A, HNF1 beta positive in both. Racemase is thought to be a little bit more helpful because it's positive usually in clear cell carcinoma and negative in area-stellar. However, in the case I've shown you in the 14-year-old patient, it was negative, so not very helpful. Ki67 is also not very helpful, is low in area-stellar and can be high in clear cell carcinoma, but sometimes can be also low. And these markers, I don't have it in my lab, so I cannot use it. ASS1 is thought to be and described by some authors to be helpful, being negative in area-stellar and positive in clear cell carcinoma. And I give you this example of a 31-year-old patient who was 12 weeks pregnant, and this is a polyp that was removed from this patient. As you can see on the left-hand side, there are endocervical glands that look normal, but also here in this red circle, you see some glands that look a little bit different, a little bit more busier architecture. And when you look at the picture on the right-hand side, you see that these glands are lined by cells that have more eosinophilic cytoplasm, and it's a little bit pseudo-stratified, some micropapillae, not really true papillae, but some micropapillary area, and you start seeing these nuclei that look atypical and hyperchromatic. No mitotic figures present. And when you do clear cell markers, Napsin A is going to be positive in these glands that are with busy architecture and are actually glands involved by area stellar reaction, and nepsin A is going to be negative in the normal endocervical glands next to it, and then HNF1 beta again is going to be positive in the area stellar reaction and negative in endocervical glands. Estrogen receptor is, as you can see here, strong and diffuse positive in the normal endocervical gland, and it is positive but less diffuse and weak in the area stellar reaction, and Ki67 index is low. So this was my third case. If you have any questions.
Thanks, Simona. That's amazing case, especially the age of the patient. Was uterine biopsy suggested for this patient as well, just to rule out the potential of primary uterus?
Yeah. So I was told, because I haven't seen the biopsy, but I was told that the biopsy was suspicious. But they couldn't believe it because clear cell carcinoma is rare to start with. And probably this is one of the youngest patients I have seen with a clear cell carcinoma. So they couldn't believe that the HPV testing was negative. And she has an endocervical adenocarcinoma at that age. We said that probably they should perform a cone, and that was how the cone was looking like. So it was really a surprise. It confirms that she was HPV negative because these lesions are HPV negative, it also confirms that. I shouldn't say this, but you should co-test the patients in a screening program or in any kind of situation, because HPV testing is not enough. It's only because she has performed a pap smear they found this tumor, because the tumor was not clinically visible and she didn't have any symptoms. It was only because she started her sexual life and her mother was a little bit worried, and the mother wanted the patient to be tested for HPV, and they also perform a pap smear. So it's another situation in which life tells us that we should co-test these patients and not only test them for HPV in a screening program.
I'm just reading the comments. Someone, Dr. Amani Hassana, said she had a case, a 17-year-old trachelectomy, but the tumor recurred, unfortunately. There's two. I'll just ask you two questions. I think they apply to this general category of HPV-independent AIS. And the first is, can you elaborate on whether the kind of extent of this process in any one patient, or the degree of architectural complexity, how that plays into these diagnoses or not?
Not much, because as you can see, some of them look really well differentiated, let's say. All of these lesions are not graded in the routine practice, but they look like well differentiated. So the morphology is not very helpful. The architecture is not very helpful. What is helpful is to have an open mind and to know that these cases do exist. And then any atypical features that you can see, you should correlate with immunohistochemistry, clinical background, and so on.
The other thing is about, you mentioned a bit on your experience with CA9 as an immunohistochemical marker in the cervix, and that may be something that our colleagues that are not in oncology centers, that are out doing their work in the community, they may have access to. And so if they find themselves in a situation where they may be considering a diagnosis like this that they may not have experience with, is CA9 a helpful in this circumstance, not just for HPV independent, the HPV independent spectrum, but you mentioned in the kind of neoplastic spectrum in general? Is it something helpful that people should use?
Yeah, so in our IACC cohort that we published in 2018, when we collected hundreds of cases of endocervical adenocarcinomas, both HPV-associated and HPV-independent, we did perform a panel of markers to help with our diagnosis and to propose an algorithm based on these markers. And we found that CA9 was extremely useful, was always negative in benign endocervical lesions and in normal endocervical glands, and was positive always in malignant lesions with glandular differentiation, both HPV-associated and HPV-independent. So even in the gastric type, endocervical adenocarcinomas was positive. So we thought that it's going to be interesting to use this in our practice. I don't know what's your experience, but in my experience, it works. It's something that is not very sophisticated and not very expensive and can help in differential diagnosis.
Sounds good. I personally don't have any experience with it in this context, so I can't comment. Thanks, Simona. Perhaps we will move on to Dr. Emily Goebel. Yes, from London, Ontario.
Hi, thank you. All right, so I'm going to talk about briefly a case that came across my desk. The lesion is not exactly in the gynecological tract, but it can occur in the gynecological tract, and it happened in a obstetrical context. So she's a 25-year-old woman who had an omental mass at the time of C-section, just kind of plucked out, sent to pathology. I don't think they really put much thought into it. Turned out it was a 1.5 centimeter tan brown homogeneous nodule with a smooth outer surface. And this is what it looked like. We had a very pink stain. I tried to even restain it to get it a little less pink, but it didn't work out. It's very pink. As you can see, well circumscribed nodule. There was a focal area maybe up here that was a bit irregular into the surrounding adipose tissue of the omentum. You can see it's a very vascular lesion, a bit higher power here. We had some areas of central necrosis, but again, very vascular with these thin capillaries here. Sort of not necessarily alternating, but various areas of a bit increased cellularity, some lower cellularity areas, maybe over here. Here, there's some inflammatory cells. This is higher power of the more cellular area where you can see these spindled cells. Some of these nuclei have some tapered ends here. You can appreciate these thin-walled vessels and this smattering of lymphocytes. I think there were some neutrophils kind of in the vicinity of the central necrosis. Not a ton of atypia, I would say hardly any in terms of our, the context of spindle cell lesions in the gynecologic tract. Pretty uniform cells. They were arranged kind of in short fascicles. Here's another low hypocellular area with a bit of a myxoid appearance here. You can see it's kind of blue material here. There's 1/10 mitoses, highlighted it there. So not a lot. And importantly, this was away from the necrosis. So when I'm counting mitoses in spindle cell lesions, you don't really count them near the necrosis because it can be artificially elevated. Okay, so we did an immunohistochemical panel, positive for both CD10, so stromal type markers, and SMA and Desmond to a lesser degree, but smooth muscle markers were positive as well. I don't have a PR, but I imagine it would be diffusely positive. We have some weak ER positivity here. And because this is in the omentum, we wanted to rule out some other things. So we did S100 negative. For a GIST is a possibility in this case. So we did DOG1 and CD117, which were also negative. And lesions like solitary fibrous tumor, for example, or a vascular lesion, given that there was a lot of vessels here, although we weren't really going down that line, CD34 was negative. We did one other stain, which knocked our socks off, which was ELK, and it was diffusely positive in this case. This marker is generally good enough. This type of positivity is generally good enough to indicate a fusion in the ELK gene. But given the context, we sent it for molecular to our pathologist in Mount Sinai to do the sarcoma and fusion panel workup, and it did in fact have an ELK fusion, which is again not surprising given the degree of positivity in the immunohistochemistry. So the diagnosis here is an inflammatory myofibroblastic tumor. We see it in the gynecologic tract. It can often be mistaken for things like leiomyomas, but in the omentum, I've never seen a case. So these are considered by some indolent, low, by others intermediate malignant potential. Some features that may be associated with a more aggressive behavior are things like necrosis, a larger size, greater than 7 centimeters, moderate to severe atypia, none of which we had in this case. We thought that the central necrosis was more likely related to ischemia. We didn't have a high mitotic activity, or of course, lymphovascular invasion would be some other concerning features here. These have been described and have been related to pregnancy. So they can actually involve the placenta, but don't always have to. Other sites have been described as well in the context of pregnancy, like tonsil, trachea, breast, and cul-de-sac. Given the amount of progesterone on board in pregnancy, they can sort of have sometimes a deciduoid-like change in them. We didn't have that so much in our case, but we did have a bit of necrosis, which has also been described. These are generally hormone positive with strong PR, which I didn't show you here. And we had some weak positivity. So that was consistent with that. These lesions, particularly in the context of pregnancy, are enriched for fusion partners like THBS1 and TIM3. And these are also known to be related to endometrial remodeling in placental implantation. So that kind of fits. And in the context of pregnancy, again, these appear to have an indolent clinical course. With regard to mesenteric IMTs, which is what we have here, it's a reliable and prognostic indicators have not yet been developed for IMTs. ALK positive tumors more frequently occur in younger individuals, as we had in this context, and local recurrences can occur in approximately 25% of extrapulmonary IMTs, depending on the anatomical site and resectability. I actually don't have any clinical follow-up for this patient, but it was plucked out, a fairly well circumscribed nodule. So, I mean, it's left to be seen, but I don't think this had any concerning characteristics or clinical characteristics or morphologic characteristics in this particular case. Okay, so I think the take-home point here is IMTs can happen anywhere. They do happen in the gynecological tract, but if you have anything unusual, a spindle cell lesion that has any sort of myxoid or fascicular growth, a tissue culture-like or nodular fasciitis-like appearance, as well as a lymphoplasmacytic infiltrate, we should always have IMTs on the differential because they can commonly be confused for things like smooth muscle tumors. And that's all I have.
Awesome. Thanks, Emily. Bit of a strange one, right? You have to think that somehow the pregnancy was related to this, to the association of IMT, but you didn't find anything in and around the placenta, eh?
No.
Yeah.
Oh, that was fine. Yeah, the placenta was normal.
Yeah. Simona, what do you think?
I have never seen this type of tumor in the omentum, first of all. I think they're very rare, but we have to, be open-minded and think that it can occur. I wanted to ask Emily, how about the scenario in which the tumor looks morphologically like IMT and the genetics tell you that this is an IMT, but the ALK is negative? How do you deal with this?
Yeah, I mean, I think the ALK fusion partners are the most common, but as we've seen in, ROS1 is another example. And I'm not going to put Anjelica on the spot. She gave a very nice talk of IMTs at USCAP. So yeah, we do know that there are other fusion partners associated with it. And if you're convinced or you have a high degree of suspicion morphologically, then I definitely encourage to pursue molecular avenues to confirm the presence or absence of another fusion partner. And actually, even in the instances where we have in the uterus, where we had very convincing morphology and negative molecular, we still raise the strong possibility. I'm talking outside of this case in other experiences, we still raise the strong possibility that it could be an IMT with an unidentified molecular fusion.
Yeah, sometimes the IHCs both for ALK and ROS is pretty good. I mean, it's not always diffuse strong like you've shown. It can be actually quite subtle and pinpoint and granular and such. Sometimes the molecular actually misleads you and you get a false negative because of these weird cryptic fusions and stuff like that. And sometimes fish can be a little bit more helpful, but sometimes fish can confuse stuff. So it's not perfect. That's for sure. And yeah, I think people do make the diagnosis, as you said, Emily, even when everything's not 100% as you would want it to be, people still go ahead and make the diagnosis with good morphology for sure.
Yeah, and I should emphasize what you just said as well. Like we had the strong diffuse positivity here, but I have a very low threshold. Like with the morphologic features and any degree of ALK positivity, I would go for confirmatory molecular testing with weak staining. I mean, I have done in the past where there's been strong diffuse and just called it without the molecular, but in the context where there is, don't write off or dismiss weak or patchy ALK staining for sure. It can still be present. Or it can still be an IMT, I should say.
And generally speaking, Emily, in the pregnancy-related mesenchymal lesions, they sometimes can look quite weird.
Right.
Yeah, so we don't know how many of them. We used to call them pregnancy-related leiomyomas. Do you ever perform ALK stain? Do you think we're missing something here?
Well, I think honestly, this one didn't fit everything. Like the IMTs that I'm familiar with have much more appreciable tissue culture, have very evident plasma cells and lymphocytes. But when I started reading the literature in pregnancy, they of course look different. They can have that deciduoid morphology. The plasma cytoid or plasma cell infiltrate is not that prominent. They're usually lymphocyte prominent, and they have. And I mean, this one wasn't even really that cellular. So I just wanted to call. I knew it had a name. I wanted to make sure I got the right name, so I worked it up, right? But yeah, I think again our threshold should be lower in the context of pregnancy because things can look a little bit different.
Thank you. Great case.
Thanks, Emily. Appreciate it. I think we are at our time. So I'm going to hand it over to Dr. Plotkin. I'll just say thanks everybody for joining, and thanks to all the presenters. And it's always such a pleasure seeing all the cases. And of course, thanks to Dr. Stolnicu.
I will just echo what Anjelica said. I think we've heard today so many unusual things. And just to remind everybody, we started from HPV-independent squamous cell carcinomas of the cervix. And we discussed a number of immunohistochemical stains that can be super helpful in the clinical practice. And I think something to consider is CA9, definitely for those of us who use it for GU for sure. And I think we also had amazing cases from the community. So thank you so much, all the presenters. And Simona, thanks so much for joining. Thanks so much for providing this insightful feedback to all the cases and staying with us until the end. And thanks, Anjelica, for being amazing moderator.
Thank you so much, both of you.